So our speaker is Mansur Shomali. Mansur is in the endocrine division at our sister hospital, whether it's sister or brother, I don't know, of Union Memorial in Baltimore. Also an associate professor at the University of Maryland. He has a degree in biomedical engineering from Johns Hopkins undergraduate, then went to medical school in Canada at McGill, where he earned his Doctor of Medicine and Master of Surgery degrees, followed by internship and residency at the University of Maryland, and then an endocrinology fellowship at the Mass General in Boston and Harvard University. He's been involved in the care of diabetes patients his entire career. As I mentioned, he joined Union Memorial Hospital shortly after his fellowship in 2002, but he attained his faculty position at the University of Maryland, where he still teaches. He's been very productive, both in managing the endocrinology and weight management program at Union Memorial. He founded and directed the endocrine fellowship program there for a number of years. He's been productive in publications with over 30 peer-reviewed publications and 3 books on diabetes. He's also currently chief medical officer of a tech firm called WellDoc that has developed and supplies digital apps for managing type 2 diabetes, well, all diabetes actually, and he'll tell us about that in his talk. I would just mention that his most recent publication in 2022 in Clinical Diabetes was entitled Diabetes Technology in Primary Care. The future is here, almost. So hopefully today he's going to tell us when he can retire the almost from his title and when the future really will be here in terms of diabetes technology. So Mansur, welcome to Georgetown Medical Grand Rounds, and we look forward to what I know is going to be a very engaging talk.
Thank you very much, Joe. It's a real pleasure to be with you all at Georgetown. And I'll just say that this talk is a CME talk, and so I'm not going to be actually discussing some of the work I'm doing at WellDoc. But if you want to know more, any of you want to know more about the awesome stuff that we're doing in artificial intelligence and diabetes technology, I'm happy to discuss that. But I won't be discussing our products just to keep this the CME rules fair. So let's get started. Let me tell you about a couple of patients of mine that I think will reverberate because you've all seen patients like this. So Mark, who I have as his tagline, frustrated with his diabetes care. He's 57 years old. He's had type 2 diabetes for 10 years. He's been mostly prescribed non-insulin therapies over those years, but he was recently started on a once-a-day dose of basal insulin. His most recent A1C was high, 8.2%, and he's checking his glucose almost every day with his meter, but he doesn't know why his A1C is not coming down despite being told that insulin is the most powerful medicine for diabetes. So I don't even have to ask you all. I think every one of you has patients like Mark in your practice. And then I'm going to tell you about Amanda, whose tagline is she's having trouble figuring out how much insulin to take. So she's 46 years old, again, type 2 diabetes for 6 years. Her fasting glucose readings on her meter are generally good, but her post-meal glucose readings are all over the place. And at her recent visit, I sat down with her, or you sat down with her. She's really someone that we see all the time in endocrinology and in primary care as well. And we asked her, hey, you've got to match your mealtime insulin dose with what you're eating. But as she left that visit, she wasn't very clear on how she was supposed to do that. And her glucose levels didn't improve very much. Again, I hoped by telling you about these two patients over the next 30 minutes or so, you'll see how technology can help support their diabetes self-management. I wanted to step back before I dive into the technology to talk a little bit about the framework for how we improve our healthcare system in general, the ecosystem that we call healthcare. In 2007, the Institute of Healthcare Improvement published the Triple Aim, which says that healthcare systems should improve patient experiences when they need health-related services. We need to improve outcomes and lower costs. And so this was the so-called triple aim. With every arrow, there's a text box underneath that has the lens of technology on the aims that are shown in the arrow. So in 2014, Bodenheimer and Sinsky, who are primary care physicians, added clinician well-being to the aim of healthcare. And that's because the reports were that we were getting physician burnout at rates never seen before. We were dropping out of the practice of medicine, frustrated with healthcare. The EMR was driving us crazy. And so they said, wait a second, another aim, let's make this a quadruple aim, should be the care of the clinician and making sure that we're not overly burdened. So we absolutely embraced that addition to the triple aim to make it the quadruple aim. And then most recently, people are saying we have to add a fifth aim, and we'll call it health equity, because there's such a disparity in care among different socioeconomic and ethnic groups. When you take the lens of technology to these aims, you find that on the triple aim side of things in blue, technology can be difficult for patients to use. It can be unreliable. Sometimes it works, sometimes it doesn't. Very frustrating. And we're asked to use technology without any proven outcomes. You know, we don't do that. In healthcare, we are, it's in our core to test things and do studies and base what we do on science, but technology seems to be not quite that way. And not only is it lowering costs, it's expensive. We all know how much MedStar spent on MedConnect. So this is a very expensive proposition. What about clinician well-being? Well, technology is actually often difficult to prescribe, time-consuming to utilize, creates data overload and burnout for clinicians, and it's not really compatible with our workflow. So, you know, how is that helping clinician well-being? It's not. And then finally, with regard to technology, there's a huge disparity. If you look at challenged populations in Washington, in Baltimore, wherever you are, there's a huge discrepancy between who's using technology effectively and who's not. So again, there's this quintuple aim, and I feel like we're far from meeting it. And so as we sit through and listen to all the amazing things that I'm going to describe in the next few minutes, let's keep that in the back of our minds. And Joe, that's the reason why in my editorial in Clinical Diabetes, I said the future is here almost, because we've got lots of things that are built in software and hardware, but we haven't figured out how to make it easy, how to improve outcomes, how to lower costs, and how to make it serve our needs in the clinic seamlessly as it should. Here's a 2x2 chart that I kind of created. You may or may not agree with me, but if you take a look at the axis from left to right, high clinician burden to low clinician burden. And then if you look at the squares from top to bottom, interventions that do not improve quality of care and interventions at the bottom that do improve quality of care, we want to be in that light blue box at the bottom right, where we have an optimal investment in technology, where we can see the number of patients we need to see, we can get a great return on our investment, and we have great patient experiences when they visit us. If you're in any of the other boxes, it's just not as good. We're costing more, our outcomes aren't better. And in the top right, I call it the hamster wheel, where we're not working better and patients aren't getting better, but we're seeing patients one after the other, right? That's the hamster wheel. We don't want to be in that box. That's not a good place. We want to be in this optimal place where, you know, it's not hard to actually get the outcomes that we really need. I think that technology, when done right, can help us get into and stay into the light blue box. And that will be my proposal to all of you, is as over the next few years, we're going to make this technology seamless and better and more robust so that it does the things that it's really cracked up to do. So I'm going to tell you about simple things like what's new with blood glucose monitoring with a meter. I call that BGM, but we'll also talk about the continuous glucose monitoring revolution, or CGM. And as you know, that's sort of this particular technology is really transforming how we manage diabetes today. I'll touch a little bit on automated insulin delivery systems, which is really still mostly in the realm of specialists like endocrinologists, but more and more primary care doctors will be seeing patients on these devices. So I thought it would be nice to talk to you about this as an emerging technology. And finally, I think in the next year, we're going to see a lot more connected insulin pens. So when patients come to clinic and you ask them how much insulin are you taking, and they're not really taking their insulin, you'll know, and you'll be able to make the appropriate adjustments and interventions. I'll start off with my first clinical question. And what I'd like you to do is just enter your responses in the chat, and I'll just see how many of you agree or disagree with me. So let's take people for a moment who are not on insulin, people with type 2 diabetes on non-insulin therapies. The question is, does owning a blood glucose meter, has it been shown to improve glycemic outcomes in those individuals, true or false? I'll give you all like a second to type in true or false into the chat.
Or A and B.
Or A and B. Tell me what you're seeing, Joe.
I'm seeing a preponderance of B and no, but there are a few A's there.
Yeah, and I think you're all right. And maybe the question was a little bit leading, right? So here's data from a really nice study that was published a couple of years ago in JAMA Internal Medicine, where the investigators supplied people with type 2 diabetes not on insulin with a meter and said, test your blood sugar every day. And then they followed them for 12 months. There was also a group that wasn't expected to test their blood sugar every day. And then there was a third group that got text messages based on what their blood sugar readings were. And over the course of the 12 months, you'll see that there were no significant difference between the groups. They started to differentiate in the middle of the year, but then 12 months into it, there were no significant differences in the glucose numbers among the three groups. And again, these are people that are just given a meter. They're not told what to do with it or how to interpret the data. And so the cynical conclusion is that blood glucose meters don't help, but the nuanced response is, well, let's look at other studies. So in the Polanski's STEP study, what you see here is two groups, the control group that got usual care, and then the STEP group, which is actually in the lower, the triangle data points. And in that group, people were given a meter and said, wait a second, don't test your blood sugar every day. I want you to test 7 times on a certain day once a month. And here's what we want you to do with that information. So before breakfast, after breakfast, before lunch, after lunch, before dinner, after dinner, and at bedtime. And the people who actually were told to check in this very structured manner, they had a significant A1C reduction that persisted over the course of the study. And so for me, what it says is that glucose meters are useful because people can't know how they're doing if they don't have the data, right? But we have to teach them how to test intelligently. We all have our ways of doing it. I never tell them to check 7 times once a month. But the lesson is, if you give them, say, a strategy once a week or twice a week, check before dinner and after dinner, see what the cause and effect are of your various food choices, and then make a note of that and then do better the next time. So that's what I call structured glucose testing with a meter. It can help people, even people who aren't taking insulin, but just giving them a meter with, and prescribing it isn't gonna get the job done. The other thing about getting people's A1Cs better is that people don't really have a good way of sort of understanding what their blood sugar should be. And I see this all the time. A patient comes to my office and they're like, well, doc, what should my blood sugar be? And I said, well, you've been my patient for like 5 years. I haven't explained that to you, really? But they know what their A1C should be, right? We're so A1C driven. But the day-to-day self-management is so far removed from that A1C number is so far removed. They need to know what should their micro behaviors be on a day-to-day basis so that their A1C gets better. So in this graph, my diabetes mentor for Mass General, David Nathan, and his group put this together. And they actually plotted A1C versus average glucose in a large data set. And they found the correlation. And it turns out that we now know if you want your A1C to be less than 7, your average fasting glucose should be less than 154 milligrams per deciliter. But not only that, one of my colleagues, Louis Monnier, who's an endocrinologist in Paris, he made the correlation of A1C with fasting and postprandial glucose. So if you look at this graph, the people with the lowest A1Cs on the right, most of their hyperglycemia is from postprandial hyperglycemia in purple. Whereas people with A1Cs that are really high on the left, most of their hyperglycemia is fasting. So like Mark, my patient at the very beginning of the study, his fasting glucoses were pretty good. His A1C was in the 8 rate, close to 8. So he was on the left side of this curve, but he wasn't testing post-meal. So he would never see the post-meal hyperglycemia that was keeping him from getting less than 7. So that in that case, the American Diabetes Association has published a guideline that said, let's give people targets of where they should be in the fasting state, which is 80 to 130 milligrams per deciliter, and where they should be after a meal. Now, that's less than 180, but that less than 180 is the peak. So no one really knows when their glucose is going to peak. Usually we tell them to check 2 hours after a meal when it's even started to come down now. But so with blood glucose meter testing, you only get a few data points here and there. But I tell my patients, look, fasting, here's where you should be. And post-meal, you shouldn't be above 180. Now, the other thing I actually make sure they understand is that they don't have to meet these targets 100% of the time. And they shouldn't feel like failures if, Easter Sunday or Thanksgiving, they have a big dinner and they hit 250 after that. They just have to be in these targets most of the time. And if they're not there most of the time, then they have to call me or make an appointment so that we can make an adjustment in the treatment plan. Now, with regards to advances in blood glucose meters, just about every company now makes a meter with a Bluetooth chip built into it. And that means that the finger stick can actually directly go into an app on their smartphone if they choose to use it. And that app helps people track their readings. So gone would be the days of blood-stained paper logbooks. Not only that, but if their phone is connected to Wi-Fi, which most people's phones are, then the data goes into the cloud and then the clinicians can access it through a portal. So this is an example with the one-touch variometer. All the other major blood glucose manufacturers are making devices that work similarly. The Livongo meter on the right is actually a little different because that meter has a cellular chip built in. So even if you don't have an app on your phone, the data is sent directly by cellular signal to the cloud, and then a report can be generated based on that. Now, the problem is that every manufacturer has an app, has a cord, has a web portal. You need a username and a password, and you can never keep them all straight. So if you're in a busy clinic and you're seeing 10 patients in half a day, there's no way you can access all of this data, remember all of your passwords and logins, and so it's just really challenging. And this is why I say the future is here almost, right? Because in my view, when a patient comes to see me, I should be able to open up their MedConnect chart and their data should be in there automatically. There should be no reason that I have to go to another website with a different login credential and reset my password because I couldn't remember it 3 times and it locked me out, call customer service. I mean, we can't be doing that in clinic, right? So 2 companies have tried to solve that, Gluco and Tidepool, in different ways. So Gluco actually, we have this in our MedStar clinic in Baltimore, and some of you may have it in the clinics here at Georgetown, but it's a data aggregator. So what happens is the patient comes in with any meter, and the meter there's universal connections. So the medical assistant plugs the meter into one of those connector cables, and that automatically sends the data to the same place every time, and it looks the same way where you can access it. Now, MedStar hasn't paid for integration of this data into MedConnect. It would be challenging because, like, you'd have to pay gluco engineers money to come to Washington or Columbia or wherever they need to be, and then they have to integrate with our version of the Cerner system. So it's still not as good as my vision of having the data seamlessly be there, but it's an improvement because you don't have to deal with 10 different logins and passwords. It's all aggregated in one place. I'll just mention Tidepool a little bit on the right. They're more focused on insulin pump data. So Tidepool is used more by endocrinology specialists and endocrine clinics. Glucose used more by the non-specialty clinic that wants to aggregate glucose data. So let's talk a little bit about Amanda, my patient who had trouble calculating her insulin doses. And let's see how some of this technology can help her. So we know that there are a lot of Americans with numeracy challenges, and it just makes sense to let software do the hard work of calculating things like, basically, we know from surveys that 25% of Americans don't know their glucose target. 56%, I think this is probably much higher, can't count carbohydrates. 59% can't accurately calculate a bolus dose of insulin, even if we give them a formula. So these bolus calculators that do the math for patients are now becoming available on apps. The problem is that if somebody builds an app that helps somebody dose their insulin and they build it incorrectly, it could be dangerous because insulin can be a dangerous drug. So these apps that are good have to be cleared by the FDA as medical devices. And then the companies that do that kind of work incur a huge cost. So they charge a lot for these apps, and they try to make deals with health systems so that health systems can give it to their patients. Well, that hasn't happened in the marketplace. So although there are companies that make these apps, it's still hard to get them into the hands of patients who are using them. Here's data from a product built by Roche, where it shows that patients with the app-based insulin bolus calculator were more likely to improve their A1C significantly compared to usual care individuals. And I listed a bunch of companies that have actually come up with some other creative tools for patients patients on insulin, like Amanda. So in terms of these technologies, I'm talking about what I call insulin titration. Now, you all remember from chemistry lab in undergrad, the titration experiments. We sort of drip a solution into a test tube until it changed color, and we say, aha, this is how much we need to neutralize the acid or the base in the formula. So insulin titration is the same thing. You start someone on a dose of insulin glargine, 15 units every day, and then they come back and their blood sugars are high, so you increase it to 20 units and so on and so forth. It could take a couple of years before you adjust or titrate the dose so that their fasting glucoses are in target. Why not let software do that for you? And so these products that I list here are cleared by the FDA to do just that. Most of them do basal insulin titration, but a couple of them do bolus insulin titration, where you can prescribe Aspart or Lispro, one of these rapid-acting insulins, and it can adjust those insulins as well. So by the time patient comes to see you again in clinic, they're on a safe and more effective dose of insulin. This would take a lot of burden off of the caregivers, the clinicians who are manually making these small adjustments at interval times. So it could be really great, but again, these apps are really hard to come by because they're sort of they exist, they've been cleared by the FDA, but there's no way to pay for them. They're prescription only. How do you prescribe software? So as healthcare ecosystem, we haven't figured out how to get these into the hands of patients and clinicians who need them the most. But I think that we're at a turning point. We're at a pivot point. So over the next couple of years, everybody with every disease will have an app for their disease. You can have heart failure, you could have a pituitary tumor, Joe, and be hypopit and have an app on the phone that sort of gives you coaching on what to do in certain situations. So I feel like digital health is really snowballing into a real thing finally. And so over the next couple of years, we're going to see more and more individuals with chronic conditions like diabetes helped by these softwares and medical devices, as the FDA calls them, SAMD. So Amanda, we prescribed her an insulin bolus calculator app, one of the ones cleared by the FDA. She felt more confident with her insulin dosing. They tracked her glucose and insulin data and reported them to the diabetes educator with whom she consulted. And over time, her post-meal glucose readings improved significantly. Now, one thing is that I wanted to put a plug in for is we're lucky at MedStar because we actually have a diabetes boot camp service. So if you go into MedConnect and you enter MedStar diabetes pathway in the orders, and then you sign it, that patient will be contacted by a MedStar diabetes educator, and they'll be enrolled in our diabetes boot camp program, where we actually will match that individual with diabetes with appropriate technology, and we'll follow them for 12 weeks under protocol, and then we'll turn them back to you with a repeat A1C, which hopefully will show a significant improvement. So this is a really great service that we have for MedStar patients that I encourage those of you who are struggling with people with very high A1Cs that need the extra help. Feel free to get patients enrolled in the diabetes pathway. Any quick questions in the chat before I turn to CGM?
One just quick question I have, Sean Welton, Medicine Program Director. Is that diabetes order, is that accessible across the entire MedStar platform, or is it regional?
No, I believe everyone has it. We have it in Baltimore, you have it in Washington, and it's basically the same protocol. It is across the entire system. You have to be a MedStar patient, though. So if you're a MedStar provider, then you can order this for your patient.
And all the interactions the patient would have would be virtual? Or in person?
Yeah, no, we use a lot of technology where it can be done virtually. So we get their glucose data over the cloud and we review it, and the educators are really good at this now. So especially during COVID-19. So most of the visits are virtual, actually.
This is great. Thank you.
Thanks for your question, Sean. So let me continue the story of technology by talking about the exciting field of continuous glucose monitoring. So I talked about BGM users, and now we're going to talk about CGM users. There are 4 CGM platforms that are cleared by the FDA in the United States. But there's only 2 that you will probably be using. So it's not going to be that complicated, I don't think. The Dexcom G6 product is there's a picture of that on the very left. And then the Freestyle Libre product is the third one on this screen. I'll point out the Eversense system, which is interesting because it's a Maryland company, and the sensor is actually implanted, and the glucose sensor is implanted under the skin of the forearm, where it can remain up to 6 months. And then there's the data is actually sent to an app, and then reports can be generated for clinicians. So that's a system that actually is very interesting, but there are very few users because the clinicians have to learn a surgical procedure to implant the sensor, and insurance coverage isn't there, and the company is really struggling to get a foothold in the marketplace. But we'll see what happens with Eversense, if it's going to succeed and take off or not. But it's a good technology, just isn't widely used. The system on the very right, the Medtronic system, they do have a sensor. Medtronic is known, besides there are defibrillators and cardiovascular devices, they're known for their insulin pump system, and they have the first automated insulin delivery system. But people usually don't prescribe their sensors for CGM in non-pump patients because it only works with their system. And there's a feeling that maybe their data is not as accurate. I don't think that accuracy is the main issue. The main issue, in my view, is that the FDA has not cleared that system for use for insulin dosing unless the patient does a finger stick. So imagine you're prescribing a continuous glucose sensor to a user and say, but you still have to do finger sticks before knowing how much insulin to take. So it's just kind of tough. So when Medtronic gets a more accurate sensor where the data can be approved for use for insulin dosing, I think that system has a chance of being used more in the marketplace. So let's talk a little bit about CGM. So here's a patient who's got a Dexcom CGM as an example. They're wearing the sensor on their abdomen, or they can wear it on behind on their buttocks, on their thigh, or maybe even on their arm. And the data is continuously updating in an app on their phone. They can also use a dedicated hardware reader, or if they have a compatible watch, they can see their glucose data updated every 5 minutes on their watch. Not only do they see their glucose data in real time, but what's critical is that there's an arrow next to the blood glucose value. It's actually not a blood glucose value. It's an interstitial fluid glucose value because the sensor is not in the blood compartment. It's not in a vein. It's actually under the skin sampling interstitial fluid, which correlates, of course, with blood glucose, not perfectly, but close enough for real life applications. But what you'll see here is this trend arrow. So a person whose blood glucose is 110 here, and the arrow is level, means that glucose is not changing very much. It's very stable, changing less than 1 milligram per deciliter per minute. Imagine then the patient had a data on the right where the glucose is 110, but the arrow is down. The down arrow means the glucose is changing up to 3 milligrams per deciliter per minute. So a glucose of 110 that's dropping requires action. That patient should probably have some fast-acting carbs to avoid dropping below 70 and becoming hypoglycemic, whereas the patient on the left doesn't have to worry about that. The same holds true for the use of the trend arrow when the glucose is high. So in the bottom left, someone's glucose is 256 and dropping. Well, you don't have to do anything at that time. It's high, but it's dropping into range. So no need to overreact, no need to take extra doses of insulin and get into trouble. On the other hand, if the glucose is 256 and stable, it might be time to teach your patient how to take a correctional dose of insulin, which can bring the glucose down into target and improve glucose outcomes. So as you can see, CGM can be quite helpful in influencing in the moment behavior that can keep the glucose within the target range. So here's a question, another question to the audience I want Joe to work a little hard in this grand rounds that he's hosting. So let me read the question to you. CGM has been shown to be beneficial in which of the following groups? A, people with type 1 diabetes. B, people with type 2 diabetes who are prescribed intensive insulin therapy. And C, people with type 2 diabetes who are not prescribed intensive insulin therapy. Like they might be on just pills, or they might be on a once a day long-acting insulin, but they're not dosing their insulin with every meal. That's group C. Answer D would be A and B only, and answer E would be A, B, and C. So let's hear your responses.
Okay, I'm seeing more responses now. So the preponderance so far is D, but with a few E's mixed in as well, I would say.
Yeah, my
70% D, 30% E.
Yeah, good, very good. So the answer is E. And let me show you some of that data because it's really surprising, right? We always thought, okay, CGM in an intensive insulin user, it's going to be helpful in dosing your insulin. So let's talk about the data. So here's data from people with type 1 diabetes, and it's a crossover study. So in the CGM first group, that's the filled in circles, their A1C improved at 6 months, and then the control group A1C did not improve so much. However, when the groups were crossed over, the group that received the CGM got better, and the group that had the CGM taken away got worse. So we're pretty confident that in people with type 1 diabetes who are absolutely dependent on insulin for survival, CGM is very helpful. No arguments there. But in the type 2 patients, we now have similar data. I won't show you the graphs, but I'll tell you that CGM lowered the A1C, reduced hypoglycemia. Again, in type 2 people treated with insulin, CGM is very helpful. So that's A and B. More recently is group C, the people that actually are not on intensive insulin. And the mobile study, which was published actually exactly 1 year ago, showed that CGM lowers A1C in people not on intensive insulin with type 2 diabetes. It lowered the average glucose. It caused less time in patients with hyperglycemia, that's over 250, and more time in range, the time in range of 70 to 180. So in this particular study, there was also a follow-up study where people had the CGM taken away and their glucose control worsened. So again, just about in every group studied, people with type 1 diabetes, people with type 2 diabetes, on insulin, not on insulin, CGM has been shown to be helpful. And in this particular group, the group that's not dosing their insulin based on CGM, it must be that silly arrow and the glucose value that's coming on their watch every 5 minutes is affecting their behavior. They're making different food choices when they're seeing their glucoses go high, or they're going for a walk instead of like watching the baseball game on TV after dinner. You know, I think that's why people are getting better. They're improving their diabetes self-management behavior because their data is visible all the time. Now, if you look at what time and range data we should be shooting for, it turns out that to get your A1C less than 7, you need the time in your CGM time and range to be 70% or more. And so when you're seeing a patient with CGM in your clinic, you don't look at a logbook like you would in a patient doing finger sticks with a meter. You actually get a report, and the report gives you a time and range bar graph. And you want that time in the green range to be as large as possible, and the time in red, which is hypoglycemia, to be as small as possible. And orange and yellow means your patient's been high. So the American Diabetes Association says you want to have that time and range green zone over 70% based on the data that I showed you on the previous slide. Now, if you have somebody who's a little frail, who's older, who's prone to hypoglycemia, maybe they have some kidney disease or liver disease, cardiovascular disease, the ADA says that if you can target a less intensive time and range of like 50% instead of 70%. And so you can customize these for your patients. A young patient who's healthy, who's going to have diabetes for another 30 years, you'd probably want to be more intensive. And then I won't get into it, but there are different ranges for pregnancy because of gestational diabetes and diabetes during pregnancy, really requiring intensive glucose control for patients to be well. CGM devices in the United States are not FDA cleared for pregnancy, unfortunately, but we're all using them because they're amazing and they help our women, pregnant mother patients get better. So we're using them as standard of care. They just haven't been cleared yet by the FDA. They will be, but you know, our FDA has been bogged down by the pandemic, and so technology solutions are taking a little bit of time to get through the agency. So let's go back to Mark now, who was really frustrated with his diabetes care. So we put him on a CGM system. He's got the app on his phone. He sees his glucose all the time. He's learning how to use the trend arrow to adjust his physical activity and his food choices. And then let me show you what it might look like when he comes into clinic. So you'll see a bar graph here with the time and range. He's at 47% for the time period indicated. There's a formula that actually converts that to what an A1C, what the A1C would be. So in this case, we call that GMI, glycemic management indicator, GMI. That's the digital equivalent of an A1C. If he went to the lab and had his blood drawn, he would be 7.8 on this particular day, approximately. It's not perfect, but it's sort of a good rule of thumb to follow. And you can see on a day-to-day view, his glucoses are a little bit on the high end, but more and more of them are dropping into that 70 to 180 range. So he's getting there. Now I'm going to switch to a different technology. I'm going to talk about automated insulin delivery systems, or AID. And I'm going to tell you about a patient of mine named, that's not really what he looks like, and his name's not really Mateo. But he's 52 years old. He has type 1 diabetes. He's had it for 15 years. And here's what his CGM data looks like. His time in range is 52%. We remember we want it over 70%. His GMI is 7.7, so it's above the target. And remember, glucose management is to reduce microvascular complications of diabetes, like nephropathy, neuropathy, retinopathy. So not only that, but you see that on the same day, there are times when he's extremely high and then times that he's dropped extremely low. Has anyone had a patient like that? I think we've all had patients like that. So basically put him on one of the automated insulin delivery devices. The particular model he's on is from a manufacturer named Tandem. They make a tislim pump, and this pump has an algorithm that was built by folks from the University of Virginia. It's called Control IQ. And let me just take you through this complicated graphic for just a minute. I know this might be hard for people who haven't seen an AID system before, but it makes a couple of important points. So in the top view, you have this patient's, Mateo's glucose data. The green zone is the time in range between 70 and 180. That's where we want Mateo to spend most of his time, more than 70% of his time. And now at the middle level of the graphic is the bolus insulin. So every time you see a bar graph here, he has received a bolus of insulin from his pump. And then at the bottom level of this complicated graphic, you see basal insulin delivery. And let's take point A in time, for example. At point A, his glucose is coming down, and it's predicted to come down into the hypoglycemia range. So if you look at basal insulin delivery, the system automatically shuts down basal insulin delivery so that if hypoglycemia occurs, it's going to be a lot milder. Now, he overcorrected and ate too many carbs, Mateo did, and his glucose started to go high. So at point B, what you see is not only did basal insulin delivery resume at the very bottom here, but the system gave an auto bolus. It automatically gave him a rapid amount of insulin based on predetermined configurations. And so what you're seeing here, I won't bore you with the rest of the slide because it's more of the same, but what you're seeing here is an algorithm that increases or decreases insulin delivery automatically based on real-time CGM data. And this has really been a tremendous advance for people with type 1 diabetes who are absolutely dependent on insulin for life. And then Mateo comes back to clinic, and you see that his time in range has improved to over 70%. His glycemic management indicator, the digital A1C, is 6.6, and he's just smooth sailing on most days. I mean, I picked a really good day to show you, but he's not like this every day, but it's way better than what he was before. So there are currently 3 AID systems on the market that sort of, we call them closed loop systems, but they're only really partially closed loop systems because they don't actually account for people's food choices. They do help though with correcting hyperglycemia and avoiding hypoglycemia. The 3 companies that make systems are Medtronic that I mentioned earlier, Tandem, which is the example I showed from my patient Mateo, and the most recent player is Insulet's Omnipod 5, which was just FDA cleared a few weeks ago. Because it was just cleared, it's been in a limited launch, so only very few patients, mostly in California, have had access to it. So I don't have any patients on it yet, but from what I hear, it's working really well. So these are really great devices for people with type 1 diabetes. Now, currently the ATTD meeting is going on in Barcelona. I'm attending that virtually, so I'm with you all on my lunch break from the ATTD meeting. And in that meeting, Omnipod is publishing and presenting data showing that their system actually works in type 2 diabetes as well. So look for people who have type 2 diabetes, who are taking intensive insulin, who want the flexibility and the freedom of a system like this, that may be something that is in the near future. I showed this slide to sort of make myself feel a little bit better. You know those patients that you take care of and you adjust their insulin in clinic and then they come back a month later and their blood sugars are still all over the place? And we sort of sometimes we blame ourselves. Did I not adjust the insulin correctly? Or we can blame the patient. Are they eating badly in the middle of the night? But this is data from Medtronic diabetes. And I want to show you what it shows. These are people who received an automated insulin delivery system. They turned it on at night. So, and they left it running throughout the night until the next day. So the glucose levels in the time and range are shown in the top panel. And how much insulin was delivered is shown in the purple bars in the bottom of each panel. And these are 4 different nights of the same person. As you can see here, people's nightly insulin dose to get them to wake up with a similar blood sugar every morning of about 110, 120 milligrams per deciliter is the set point. To get to wake up with 120 milligrams per deciliter every morning requires a different pattern of insulin delivery during the night. So, and this is the same patient. So when we're dosing insulin with subcutaneous injections with our patients, of course there's going to be variability. We can't account for the biologic variability. We can only do the best that we can for as much of getting the time and range close to 70% as much as we can. So when people aren't doing well, sometimes they could be doing better with their self-management behaviors, their food choices. Maybe sometimes I didn't do the greatest adjustment, but this biological variability in insulin requirements is why it's so difficult. And that's why automated insulin delivery that's responding to minute by minute glucose variations is really eventually going to be the solution here. This is a graph showing a forest plot of a meta-analysis of insulin pump data for lots of people with diabetes, right? Type 1, kids, adults, type 2, and the data is all over the place for efficacy, right? Because traditional insulin pumps relied on the endocrinologist to program the pump at clinic. And what I've shown you now is that that's not good enough because people need automated insulin delivery to change insulin delivery every minute, every hour, every night is different. So that's why AID systems are performing way better than traditional insulin pump systems that were not driven by CGM. I'm going to skip a little quickly because I want to save a few minutes for questions at the end. So I told you I would mention briefly connected pens. There are 2 systems cleared by the FDA. These are for people with type 1 or type 2 diabetes who don't want an insulin pump. They don't want automated insulin delivery. These are most of our patients, right? Very few people are on insulin pumps. Most people inject their insulin. With the Medtronic InPen solution on the left, you prescribe them an insulin cartridge that fits into this pen that has a Bluetooth device in it. And it transmits the insulin dose to an app on the phone. And then it has a built-in insulin calculator, which helps patients by recommending the correct insulin dose for that meal. So not only do you have connected data from the insulin pen, but you've got a built-in insulin calculator, which I showed you before, has been shown to really help people who are dosing bolus insulin. You can prescribe this today. It's available on the market. It's covered by many insurances, and it just requires a little bit of configuring on the first day because you have to configure the insulin calculator, and then it's pretty easy after that. The system on the right was just cleared a few months ago, so it's not really in the marketplace yet, but it uses the Libre system rather than the Dexcom system for CGM. And it has a pen for basal, which is white, black, and a pen for bolus, which is white. And so it helps people dose their basal insulin, their bolus insulin. There's a little screen here where they don't even have to use an app. The recommended dose of insulin comes on right on the LCD screen, right on the pen device. So this is a really like almost dummy-proof system that we don't have experience yet because it's not really in the market. But I think if they're successful, we should be able to get this into our patients' hands over the next year or so. I want to make a pitch for a series of educational videos that we put together at the ADA. I had a chance to participate in one of the videos. There are 9 different videos on all aspects of diabetes technology in primary care. This is for primary care providers, not endocrinologists. And we worked really hard to put this together. So you can actually log into the link that I've shown and sign up and get CME based on this if you're really very interested in improving your skills with diabetes technology.